So it's my pleasure to introduce Dr. Donna Ryan for Grand Rounds today. She originally got her medical degree at LSU and stayed there for residency and fellowship in hematology and oncology. Following this, she's been climbing the academic ranks in LSU's Department of Medicine and recently transitioned from full professor to professor emerita. She's connected to the Pennington Biomedical Research Center for that position. Looking through her CV, she's held multiple appointments, including Associate Executive Director for Clinical Research, Fellow of the Obesity Society, and a Fellow of the ACP. She serves on national and local level committees focused on obesity and the prevention thereof, including being a former president of the Obesity Society and having been invited to speak on this topic in multiple places. She served as the PI and co-PI on several large clinical trials in obesity and has published broadly on the topic both in journals and in textbooks. Looking through her list of honors, they're pretty diverse, including, notably for me, one of the most influential women in business award from Baton Rouge and the Master of Obesity Medicine award this past year.
So there are only two.
There are only two Masters of Obesity Medicine. One of them is going to speak to us right now on the new paradigms in obesity.
Cameron, thank you. Thank you for reading that. And thank you to my mother for writing it. Yeah, so really, thank you very much for having me here. My topic, these are my disclosures. And my topic is new paradigms in obesity. And I want you to take a quick look at this and then tell me, what did you see? How many people saw primarily a rabbit? How many people saw primarily a duck? So the ducks are out winning the rabbits here. So the idea here is looking at a pattern and based on your perception of it, making an identification of what that pattern represents. So, paradigm is a very fancy word. And scientists love to use it. And I think that's really because of this very influential book that came out in 1962 by Thomas Kuhn. And he defined paradigm as universally recognized scientific achievements that for a time provide model problems and solutions for a community of practitioners. So the idea is that science doesn't advance incrementally, that there are revolutionary changes that really advance the field. And so the best example of this would be the Copernican idea of that the Earth is the center of the universe and the sun is revolving around the Earth. That was then replaced by a new paradigm, Galileo's idea that the sun was the center of our solar system. And since then, of course, the paradigm has shifted yet again with much expanded knowledge of how our universe actually works. I guess in medicine, a good example of a paradigm shift would be Helicobacter pylori, which, as an etiology of peptic ulcer disease, totally transformed our approach to that disease. So that's a very fancy word, but let's admit that another definition of paradigm is that it's a philosophical way for intellectually confused people to say pattern. So it is just a pattern. It's a fancy word. But I kind of need that fancy word because, if you have a southern accent, people's estimation of your IQ automatically drops about 10 points. So I need some help here. So when I give a talk, I like to have a thesis. And my thesis is that we're in a paradigm shift about obesity. So I used to be like the guy on the right. And I looked at this pattern and I saw 3 logs. But now I'm more like the guy on the left and I look at the pattern and I see 4 logs. So my goal in this talk is to convince you that we need a new appreciation, a new recognition of what the pattern behind obesity actually is, starting with whether it's a disease, what's its etiology, the pathogenesis of obesity and how it drives comorbidities, thinking about optimal weight loss, and really how we should change our approach to treatment and prevention based on this new paradigm. So Is obesity a disease? Well, I used to say, no, it's not a disease. But now I'm in the yes camp. And I think the idea was that it's not a disease. It's really associated with diseases. It's a risk factor. That's sort of an older way of thinking. But if you define disease as an impairment of normal functioning that produces morbidity and increases risk for mortality, then obesity is a disease because it's an impairment of normal functioning of the physiologic regulation of energy balance. And that impairment does produce morbidity and mortality. And then some people argue that obesity is not a disease. If you define obesity as a BMI of 30 and up, well, there are some people who are perfectly healthy with a BMI of 30. Well, I think the new paradigm would look at this and say, look, let's not use BMI for name calling. Let's use BMI as a risk factor and a screening tool. Let's screen with BMI and then determine health risk associated with excess body weight on other factors. And then I think there's the old way of thinking is that obesity isn't a disease because anybody could change their body habitus with better habits. So it must be a personal choice. One's body size must be a personal choice. But I think the new paradigm is that obesity is based on inherited factors in the presence of an environment that strongly influences risk, and that once weight is gained, there are strong physiologic mechanisms that resist loss. So I'm in good company with endorsing obesity as a disease. It's endorsed by the AMA, the World Health Organization, and many of our professional societies. So what's the cause of obesity? What about the etiology of overweight and obesity? Well, the old paradigm, it's bad lifestyle choices. The new paradigm, it's genetically susceptible individuals in an environment that's structured to produce low levels of physical activity and ready access to energy-dense, highly palatable foods. The old paradigm would be we just need to tell them what to eat and how to exercise. It's lack of education about healthy choices. But the new paradigm would be that, healthy choices aren't always easy to make because we know now, it's been demonstrated that stress, lack of sleep, hypoglycemia, and other factors all inhibit higher cortical restraint to reward eating. And that the old way of thinking would be that, if people do lose weight and they very frequently regain, it's because they don't have willpower. They can't keep up those good habits. Well, now we know a lot about the physiology of the reduced obese state that produces a disproportionate reduction in energy expenditure and in the signals that affect hunger and satiety. So disproportionate reductions in leptin, PYY, CCK, and disproportionate increases in the hunger hormone ghrelin. I like to show these pictures to primary care physicians because I think it really illustrates what's going on with the determination of body size. So here we have pairs of identical twins, and of course they share 100% of the same DNA. They're living together, so they're under the same environmental influences, and of course there's great concordance among the pairs, among the members of the pairs in terms of body habitus. But here we have fraternal twins. So these individuals share 50% of the same DNA, living in the same environment under the same influence. And there's a lot of discordance in body habitus. So only 50% of the same DNA, but still a lot of discordance in body habitus. So can we say that this twin is not making healthy choices, or that this twin has more willpower than her sibling? No, I mean, this really demonstrates the very strong genetic component to determination of body habitus. So we now know that there are, at last count, 110 genes that influence body size, some more powerfully than others. But what appears to be going on here is that it's the aggregation of multiple risk alleles. So polymorphisms in these genes, when you aggregate large numbers of them, your risk for obesity increases. So this is a study, and there are other studies that I could show you similarly, but they're looking at just about 15 different risk alleles that have to do with neuronal influences on body weight regulation. And so it's a nice bell-shaped aggregation in terms of the number of alleles that occur across the population. But if you look at as the number of alleles are aggregated, the BMI goes up in a linear fashion. So what's going on here is that there's the accumulation of risk alleles, polymorphisms in these genes that together have an enormous influence on the determination of body size. I think another factor that's really making us understand obesity in a different way is advances in our understanding of the central regulation of food intake. And, you're fortunate here in Seattle to have some great scientists working in this area. And I think a great advance has been in extending that work into humans with the use of functional MRI and other imaging procedures, so that we now have a greater appreciation of dysregulation of the homeostatic system and the reward system that can occur in obese individuals. So, what about how does obesity produce disease? So I think the old way of thinking was that obesity was associated with other diseases like type 2 diabetes, but we really saw obesity as sort of a fellow traveler alongside these other diseases. But now we know that it's really a driver of these comorbidities. And the driver part of it is because fat tissue is now known to be an active endocrine organ and produce lots of products that have adverse effects. This is called lipotoxicity. They can be pro-inflammatory, pro-thrombotic. Fat also infiltrates organs, especially muscle and liver, and that contributes to disease. And finally, the location of body fat is very important. So fat in the portal system fat in the visceral adipose tissue depot may infiltrate the portal vasculature, affect the liver, and produce disease. So it's really this understanding of how obesity drives disease that really makes us recognize that we may not need to reduce all body fat to produce a lot of health benefits. So we know if we can lose 10% of your body weight, your visceral adipose tissue depot will decrease by 30%. So there's this, the good news is that we don't have to get everybody to reduce dramatically to get great health benefits. We can get health benefits with modest weight loss, but more on that later. It's still true that the burden of excess fat, just by its mass, can produce a disease, but that's really only part of the picture. So we know now that adipose tissue produces very active endocrine organs. These are some of the products of adipose tissue, and these are the diseases that are associated with obesity and lipotoxicity. So let's move on to our new ways of thinking about optimal weight loss. I sort of introduced that a moment ago when we were talking about how obesity drives disease. So the old thinking was, well, we need to get everybody at least under a BMI of 30 and preferably under a BMI of 25. Let's normalize everyone. But now we recognize that modest weight loss on the order of 5 to 10% can really produce some pretty good health benefits. And moderate weight loss, even more weight loss, produces more health benefits. We used to think that, okay, let's reduce people slowly, about a pound a week, and what we'll do is we'll have them eat healthier and exercise a bit more, and this slow weight loss will be ingrained habitually, and we'll end up with more weight loss long term and better weight loss. But I think now we know that initial weight loss is very important as a predictor of ultimate weight loss. And we'll talk some more about that also in a minute. And that the old thinking was that, well, people just need to keep trying to lose weight. If they're not losing weight after about 6 months, they're doing something wrong. We need to be more aggressive in treating these people. Well, now we know from many, many studies that plateaus occur with weight loss, and this is related to that physiologic adaptation to the reduced state. So in our lifestyle programs and our lifestyle aided by adjunctive medications, we usually see a plateau beginning at about 6 months. After bariatric surgery, we also see plateaus, usually beginning at about 2 years. And in both of these cases, individuals are usually not normalized to body weight of a BMI of 25. They're usually at some higher BMI level. So here's the advantage of modest weight loss, and I'm going to show you some data from Look Ahead, and this is a fabulous study. You were a site here in Seattle, and it's valuable because it's so large and so well executed. So over 2,500 individuals participating in an intensive lifestyle intervention, 2,500 individuals with just a support condition. And here I'm showing you the effect of weight loss on hemoglobin A1C and fasting glucose, glycemic measures. And across the x-axis, we have stable weight, 2 to 5% weight loss, 5 to 10%, 10 to 15, and 15% or more. So, and the same thing is true here. But there's this graded response. And in the case of glycemic measures, beginning at about 2 to 5% weight loss, reduction in A1C and fasting glucose. So this relationship between modest weight loss and glycemic control is exquisite. It's very strong. It's very powerful. And another example of that is the diabetes prevention program. Also, a site was here. And in this, everyone knows the DPP story. Modest weight loss, on average about 7%, 58% reduction in risk for conversion from IGT to type 2 diabetes. Well, this is a different kind of analysis. And the data was sort of reanalyzed to look at the diabetes incident rate per 100 person years according to weight change from baseline. So look, even within the first 5 kilograms of weight loss, there's an enormous change in risk, an enormous risk reduction. And even after about 10 kilograms, there's not a lot of an additional benefit to further weight loss in terms of risk for conversion from IGT to type 2 diabetes. So we see this same sort of effect on other cardiovascular risk factors. Here I'm showing you, and again, the slides are set up in the same way with different increments of weight loss for blood pressure, systolic, strong relationship, beginning at about 5% weight loss. Same thing true for diastolic blood pressure. Triglycerides, also very tight relationship with weight loss and improvements in triglycerides. HDL, beginning at about 5% weight loss, we see nice increases. You know, it takes a lot of weight loss to really have an impact on LDL. It's not something we expect to see. And indeed, we didn't see any change in LDL across these different weight loss increments. But I want to point out that even though there's no significant difference in that LDL, there was a reduction in lipid-lowering medications in the patients who were on the intensive lifestyle intervention. So a modest effect on LDL. This is true for impact of weight on quality of life measures. And here I'm showing you a data from pooled non-surgical weight loss studies that looks at incremental improvements in quality of life scores according to category of weight loss. And we see this same relationship, more weight loss, more benefit. But benefits really begin at lower levels of weight loss. So summing it all up, a little bit of weight loss is good. It's very good for glycemic measures and triglycerides. At about 5% weight loss, we start to see benefits in blood pressure and HDL. At about 10% weight loss, we start to see benefits in hepatic steatosis and NASH activity scores, in apnea, hypopnea index. And then with even further weight loss, if we can get above that, so an average weight loss of 16% or more in the Swedish obese subject study was associated with reduction in cardiovascular events, reduction in mortality, reduction in cancers in women. The other reason that we really need to try to maximize weight loss, because more weight loss will produce more health benefits, is because initial weight loss is a strong predictor of ultimate weight loss. And so here again, I'm showing you the DPP data. And it's divided into three groups. Those who did very well, lost 10% or more in the first year. Those who did fairly well, 5 to 10% in the first year. And those who didn't really do so well at all, less than 5%. And they're roughly three equal buckets of individuals. And so what you can see is in each of the panels, over time, we see we're looking at the proportion who achieved different weight over 4 years of observation. So here, those who achieved 10% or more weight loss, 42% maintained that 10% weight loss over 4 years. 28% maintained 5% or more. So 70% of the people who got to 10% or more in the first year were able to stay above 5% at the end of 4 years. And the results for this middle group is middling, and the results for the people who didn't do very well is not very good. Although of the people who didn't achieve 5% at the first year, 7% made 10% or more at 1 year, and 14% achieved 5% or more. But still, only about 20% of those people were able to be rescued to get 5% or more weight loss at the end of 4 years. Another way of looking at this is a principal components analysis. And if you look at the least month-to-month weight loss, moderate month-to-month weight loss, and greatest month-to-month weight loss in the first year, you see this sort of pattern over 4 years of observation. So what's going on with this difficulty in maintaining weight loss? Well, the problem is the physiology of the reduced obese state. And there's a metabolic handicap that occurs. So this is from a systematic review of 90 studies. If you had for every kilogram of body weight loss, your resting energy expenditure is reduced by 15 kilocalories for every kilogram. And that is above the reduction in energy expenditure that's required to maintain that reduced weight. So the way this works is, here we have two individuals. This individual started at 100 kilograms and he reduced down to 90 kilograms. He's reduced by 10%. Here's an individual who's 90 kilograms and is stable. So the basal requirements for this individual are 1,850 kilocalories. For this individual, it's 2,000 calories. So there's a 150 calorie handicap that this poor guy has over here because he has been reduced by 10%. This is based on these average numbers. In some individuals, this handicap is very large. It's particularly large in African Americans. So we know that this reduction in energy expenditure varies across the population. It can be quite high. It can be 450 calories for a 10% weight loss. So that's the problem. And the problem just isn't that metabolic adaptation. The problem is also their changes in the signals that regulate hunger, satiety, and reward eating. So here we have an interesting study of a reduction of weight by, on average, 14% in the first 10 weeks with a very highly structured diet. And then individuals were followed for an additional year. And so the two are all patients, and then the completers are the two lines here. So at 14% reduction, there's a reduction in leptin levels, not by 14%, but by 65%. So there's this disproportionate reduction, and it persists even out after 1 year on where they were trying very hard to maintain that weight loss. The weight was still down by 9%, but the leptin levels were reduced not by 9%, but by 35%. So this disproportionate reduction in leptin, which is signaling the brain that of starvation and is resulting in increased hunger and reduced satiety. So the study showed, in addition to disproportionate reductions in leptin, PYY, CCK, insulin, and amylin, increases in the hunger hormone ghrelin, and increases in subjective appetite findings. So how does all this affect our approach to treatment and prevention of obesity? Well, we used to think, we'll reduce the patient and they'll be cured. But now we recognize this is a chronic relapsing condition. We used to think, weight regain occurs because the patients are going back to those bad habits. But we now see this reduced obese state as a handicap in metabolic rate and altered appetite signals. We used to think patients could lose weight and maintain lost weight if they had stronger willpower. But now we know that treatments work if they are used, that adherence to the treatment is a key to obesity control, and more on adherence later. So our patients were coming to us and asking for treatment, if at all, for cosmetic reasons. But now I think physicians, especially primary care providers, need to be proactive. We need to identify patients who would derive health benefits from weight loss. And so it should not be a cosmetic treatment, but rather a health treatment. We used to look for a silver bullet. Let's find the diet. They're just eating the wrong things. Let's find the right things for them to eat. We used to think that there would be an ideal exercise program, or that an ideal drug, or the surgical procedure. But we now recognize there's enormous variation in response to any of the treatments we provide, and we need multiple options to help patients. If patients struggle, well, they should just try again, but this time they should try harder. That's the old paradigm. The new one is, if they're struggling, they need adjunctive therapy. We need to intensify our approach with medications, with devices, with surgery. The old paradigm was, we'll try lifestyle, and if they fail, they have to fail in front of us. Then we'll rescue them with medications. But now I think the new approach is to try to, when the window of opportunity is open for a weight loss effort, to stack our treatments, to give the maximum intensity behavioral approach that we can with medications if needed, if the patient has a history of struggling, and we need, because we want to get this initial weight loss, because we think that will produce better weight loss maintenance. We used to really search for the perfect medication, but I think we now recognize that there's no right medication for every patient, that patient profiles differ, drug profiles differ. We need to really use combinations of medications with different lifestyle intensities, combinations of medications per se, so that we can use reduced doses and still get efficacy. We used to treat for just the short term. Medications were approved for 3 months on average, and they were taken for 3 months on average. But now I think there's growing appreciation that the value of medications is really in sustaining weight loss maintenance, that we can use a variety of efforts to produce weight loss, but the value of these medications is as a foundational for weight loss maintenance. So here's the problem. This great look-ahead study showed you had lots of health benefits from that initial weight loss. But here over 10 years, you can see the problem with weight regain. So there was a differential was maintained between the support condition and the intervention, but it was really only about 2.5% at this point. So it was enough to demonstrate some of these improvements, especially out here where our intervention was active. This is just observational follow-up. We could demonstrate some improvement. It wasn't enough to demonstrate a reduction in cardiovascular events. So the other thing is that I'm showing you average weight loss. The amazing thing about weight loss is the enormous variation in response. So, indeed, the variance is usually equal to the amount of weight loss. It's phenomenal. So, yeah, there was an average weight loss in that first year of almost 9%. But look, there were still about there were about 32% of people, about a third of the patients didn't even achieve 5%. So that's not very good. Almost everybody lost something, but 7% of patients actually gained something. So there's this enormous variation in response. And so our approach is really to, if patients can do well with lifestyle intervention, that's fantastic. I'm delighted. But many times patients struggle, and we need to add intensification options. So on a lifestyle intervention that a primary care physician could produce in the office would, on average, produce 3% weight loss, about 8% if you intensified it as much as the look-ahead study. That was a very expensive amount of contact that was given to those participants. If you add pharmacotherapy, depending upon the strength of the behavioral intervention here, you can intensify your efforts. You can also get greater weight loss. And what we're trying to do is really push up the weight loss into this region. So gastric band, for example, at 3 years is associated with about 16% weight loss. Gastric bypass, about 32% weight loss, albeit with some risk associated with it. So here we have our low risk, low efficacy approaches. Here we have our higher risk, higher efficacy approaches. So I think the direction that we're going in is to really combine different lifestyle approaches with medications in different ways to really magnify the amount of weight loss. So in this study, there's a run-in where patients were given a highly structured diet, got on average 6% weight loss, then were randomized to placebo or medication, liraglutide 3 milligrams. And at the end of the year, there was an additional 6% weight loss. So from start, 12% weight loss here. The placebo patients were both of these groups were receiving support, lifestyle support. They maintained that weight loss. So the idea would be to use combinations of intensive diet and physical activity approaches with medications to get that initial weight loss. So the good news is we now have 4 new medications that have been approved in the last 2 years for chronic weight management. So our very conservative FDA has approved these drugs for chronic weight management. They're intended to be used like medications for other chronic diseases like hypertension. And so they are lorcaserin, a combination of, this is an interesting compound that's highly specific for the serotonin 2C receptor. So the 2B receptor on the heart valve is the problem with medications that were not specific for serotonin action. This is the receptor that we want to affect appetite. So this is highly specific for this drug. It has little affinity for the other serotonin receptors. This is a combination of 2 medications that have been around a long time, both known to produce some weight loss together in lower doses, produce really quite effective weight loss. This is a combination of naltrexone, an antidepressant associated with weight loss, and bupropion, bupropion is an antidepressant, and naltrexone is used to treat addiction, and in combination they produce acceptable weight loss. And then a new biologic that targets the GLP-1 receptor, liraglutide, at doses of 3 milligrams much higher than the 1.8 milligrams that's the maximum dose for glycemic control. We're also seeing some of these drugs not being scheduled, a very favorable sign. So all of these medications are required to approximate at least, on average, 5% difference from placebo in their clinical studies. And indeed, they all do. There's some variation. Some are produce a little bit more average weight loss than others. But that's what they're designed to do. But the real value of these medications is in weight loss maintenance. And this is an old study of a medication. It was actually sibutramine. But as long as the medication was continued for 2 years, there was good weight loss maintenance, whereas if patients were blindly randomized to control, there was weight regain. So when we're giving weight loss treatments, this variation is phenomenal. It's enormous. Here's a lifestyle modification alone, a lower dose of one of these medications, and a higher dose of one of these medications. These are waterfall plots. So each individual is plotted here according to weight loss. And this is really such a powerful graphic to demonstrate the enormous variation in weight loss response. So what accounts for that? Why do some people do very well and some people don't do very well at all? Well, we know from a look ahead that better glycemic control was associated with more weight loss, and that's illustrated here, that patients on insulin lost less weight than patients who are not on insulin, that men lost more weight than women. Now, is that fair? But, and further, more older people lost more than younger people. That's good for me. But in both of these cases, the difference in weight loss in men and women, in older and younger, is entirely explained by adherence. And so if you look at this, you can look at adherence in a number of ways. Adherence to clinic visits, and here we have quartiles of clinic visits. Weekly activity reported, more activity, more weight loss. Use of meal replacements, more meal replacements, greater weight loss. So this adherence is in multiple dimensions. It's not just one adherence to one thing, but it's adherence to multiple different behaviors that really is the best predictor of weight loss. And we see this again and again. Now, we also see differences in racial and ethnic groups. And this is especially true in African Americans as compared to non-Hispanic whites. And this difference is not really explained by adherence. What's interesting to me is that even though African Americans lost less weight in the first year, at 4 years, they were just the same as these other racial groups. So we believe that there are certainly probably racial factors that really there's some evidence around reductions in energy expenditure with metabolic adaptation that's more prominent in African Americans. We believe that's probably the case there. But at any rate, this adherence is multidimensional. Just because you don't adhere to your clinic visits doesn't mean you're not going to adhere to your meal replacements. So there's no such thing as a non-adherent personality. There are no non-compliant people. They just adhere better to some things than others. We believe this adherence can be biologic or non-biologic in origin. You know, if you're hungrier, you're going to adhere to your diet less well. But whatever approaches we develop, we've really got to understand the underpinnings of adherence. There's just an enormous need to better understand the neurobiology of habit formation, for example. Lots of things to really make us better adapted to this. I want to show you some data about the biology of weight loss, and this is from a surgical study. It's patients who received Roux-en-Y gastric bypass, 848. They had severe obesity. You know, the surgeons like to show excess body weight because it's a bigger number. And so if you divide by 2, you can usually get the total body weight, roughly. Okay, so here we see this nice bell-shaped distribution in excess weight loss. Some people didn't do very well at all. Some people did very, very well. So in this study, they looked at the relationship between individuals who were related, first-degree relatives, and people who were unrelated. And there was, of course, a big difference. First-degree relatives had much less variance in weight loss, whereas individuals who were just cohabiting but weren't related, they had the same amount of variation in weight loss response, which suggests that there are biologic underpinnings of this. So here, let's put it all together. The new paradigm would be that obesity is a complex chronic disease, that risk for developing obesity is driven by environmental and biologic factors in genetically susceptible individuals, that modest weight loss can improve health, moderate weight loss can improve health more, and the response to treatment is highly variable and weight regain is common. When patients struggle, intensification is appropriate, and combinations of approaches, diet, exercise, drugs, devices, and surgery produce more weight loss and more health benefit. So I think this, I'm not the only one who's out there detecting this shifting paradigm. And, our CMS, Center for Medicare and Medicaid Services, now sanctions reimbursement for intensive behavior therapy for obesity delivered in primary care services. Providers, Medicare reimburses for bariatric surgery. The AMA and others declare obesity a disease. We've got an American Board of Obesity Medicine. I'm one of the two masters. These are for the older people. And they're now about, I think at last count, about 3,000 individuals who've been certified in this. The professional societies are all engaging in this. We've got new obesity guidelines sponsored by the American College of Cardiology, American Heart Association, the Obesity Society. The Endocrine Society just put out new practice guidelines for pharmacotherapy. The FDA has come around on this, on seeing what's going on. They've approved 4 new medications, and we're seeing a lot of new investment in this research area. Some of it's occurring here in Seattle. From Novo Nordisk. And we're also seeing greater acceptance of paying for these medications. So currently about 60% of our providers will actually reimburse them. These are some of the quotes that I heard from people over the last year or so that I'd like to share with you. And so these are really prominent sort of people in the field from the Food and Drug Administration, New Drug Approval, and others. And they say it's like turning a battleship, and it is. And that everybody recognizes the problem and the direction we need to go in. I think that's true for the wise. It's true for those who are informed. And we're seeing a shift in attitudes like a pendulum swing. So all in all, that says to me, we've got a new paradigm. But our new paradigm is not going to be stable because of my thesis here that we're going to have continued change. So what's the next paradigm shift? Well, maybe it'll be personalized medicine. Maybe we'll better understand how to genotype and phenotype individuals and direct our treatments so that we can get around this problem of variation in weight loss response. Maybe we'll take advantage of the observation of the microbiota being linked to obesity risk, and maybe we can develop microbiome-based therapies, probiotics, or maybe fecal transplants. Who knows? That's possible. I think we need to really, another sort of emerging area is to understand this nutritional programming. That's the strong influence of early life, prenatal and early natal life on risk for obesity and other chronic diseases that occur in adulthood. There's still some interest in exercise in the bottle. Thermogenic drugs or brown fat activators, there's still interest in that. It's still around. And then another big thing that's going on, I don't know how we're going to harness this, is the use of wearables, mobile health, e-health, social networks to really produce better weight management platforms. So all of these things, I think, will influence our paradigm going forward. So you can argue with me. You can say you think one of these will be it, or you can come up with your own. But we're nearing the end, and it's now time. You know, I said that a paradigm was really based on perception, so it sort of depends on your perspective, where you're standing when you see this. So to me, this looks like a not very good duck and an even worse rabbit. Thank you.
I want to attest personally to this because in 2013 I was diagnosed with diabetes 2, blood sugar 524, triglycerides 2,000, a mess. Less than 4 months later, with 55 pounds off, and I increased my workout triple really to about 10 hours a week. It was completely in remission. In fact, the doctor didn't recognize me. She said she had never seen cholesterol drop that fast or whatever in all her years of doctoring. So even if you have diabetes too, it's reversible. I have no trace of it now whatsoever.
Very good observation. You know, if all my patients could do as well as you, I wouldn't need any of these adjunctive therapies. But, you know, but the truth is, and I'm delighted when patients do very well, but it's hard work doing that. Am I wrong? No, it's time consuming. It takes a lot of time. It takes a lot of effort. It takes a lot of resources and support to do that. So I think when patients struggle, we need to come up with adjuncts to help them. So thank you for sharing that. You know, I think one of the things that's really legitimized bariatric surgical procedures is not just the safety. It's not just the improvement in safety that occur with these laparoscopic techniques and better training of our surgeons and the staff that produces the procedure. It's also the dramatic effect that has on improvements in glycemic control, putting diabetes into remission. And so that's really sort of driving that interest in bariatric surgeries. Yeah.
Donna, thank you so much. That was a wonderful summary. What I have a question about the
Thank
new...
you for coming and listening.
I have the question about the new Endocrine Society recommendations about pharmacotherapy. Mm-hmm. And I wonder if your paradigm shift is also occurring in the shift in diabetes management, so that we're looking towards medications that minimize weight gain as opposed to those that promote weight gain.
Yeah. So one of the great things about those guidelines, they're free, just Google them, practice guidelines, pharmacotherapy, Endocrine Society, is that they look not just at drugs approved for weight loss. We also looked at medications that we're using for chronic disease management and that produce weight gain, alternatives that might be weight neutral or produce weight loss, all based on a systematic review. The evidence is graded, and the recommendations are graded. And so it's really a great resource. It's a first. It's the first time we've really had anything authoritative about chronic disease management that's weight-centric. You know, I think we don't really recognize that we, as physicians, are contributing to risk in the patients when we prescribe some of our antidepressants, some of our diabetes medications, and there are alternatives that could produce some weight loss or be more weight neutral. So check that out. It's a great resource. Where are those residents? Yeah.
Thanks so much for such a great talk. I was just wondering, and forgive me if you touched on this, but when do you think the right time is to refer these patients to get medical therapy? I know some of those medicines are approved only for certain BMIs. Yeah. And where that insurance will be willing to pay for that, if that's based on BMI or not.
Yeah, you know, the insurers have been slow to come around to this, but they're now there. You know, so the indications for these medications is a BMI of 30 and up or 27 with a comorbidity. But, you know, there's an enormous variation in obesity risk that can occur at lower BMIs among, say, Asian Americans and Hispanic Americans. So they can have lower BMIs and still have cardiometabolic risk associated with it. So these, you know, and I think it's more likely that the payer is going to enforce those guidelines than not. But, you know, the idea here is the concept is we're going to, as we increase risk, we want a patient profile that's higher risk. So if we're treating just for cosmetics, we've got to have treatments that are very, very safe. But we can accept some risk as health risk increases. So it's like anything else in medicine. I don't think we're at the stage yet where we can freelance on the indications for those obesity medications. It's just too new. We need to stay on the label.
There we go. You alluded to this briefly, but could you comment more on why you think there was no improvement in cardiovascular risk after nearly 10 years of the Look-Ahead study, despite impressive improvements in some of the risk factors?
Yes. Isn't that interesting? Well, I think that several things were going on. If you read the paper carefully and you look at the subgroup analysis of individuals who did not have prior cardiovascular disease, there actually was a statistically significant reduction in cardiovascular events, which says to me weight loss is not very good as secondary prevention. That where we need to be positioning this is in primary prevention. Of course, the other factors that produce that, you know, when you design these studies, I mean, it's like Scylla and Charybdis. You want a population that's going to have a high event rate so that you don't have to follow them from here to eternity. So you want to get events, so you're enriching the population with higher risk individuals, and you're at the same time you're trying to, you know, you're positioning weight loss in a population that's probably not the ideal population to study this in, but it's the vagaries of clinical trial design. I mean, look, 5,000 people, 10 years. I mean, enormously expensive, and I don't think we'll get any better than that. So I think we need to have stronger, more weight loss, more powerful interventions. So maybe some of these cardiovascular outcome trials that are required for every medication that has a central effect, maybe one of those will show an actual risk reduction, although they're all powered to show, you know, that there's going to be no difference. I still think weight loss is good for you.
Thank you. I hope you haven't already answered this. I got in a little late. Would you talk about your thoughts about the yo-yo weight loss and weight gain that some people seem to go through over, 20 and 30 years sometimes? Significant increases and decreases, and what are the various concerns about that?
That was a very hot topic about 10 or 15 years ago. And the idea that you could actually be doing yourself harm by losing weight, regaining, losing weight, regaining. And I want to be clear, there are some risks associated with weight loss. Let's just be honest about that. Weight loss is associated with increased risk for gallbladder disease. We worry that weight loss increases risk for osteoporosis and frailty, especially in older people. Look, the only good thing I can say about obesity is that it reduces your risk for osteoporosis. So I think we need to be clear about that. But there's never been anything convincing that yo-yo has any negative effect. I think it's in the natural history of the disease. I mean, once you understand metabolic adaptation, you expect it. And so I think our approach has got to be For people who are, it has to be slightly different to maintain weight loss than to achieve weight loss. You know, to achieve weight loss, you're trying to produce 500 to 1,000 calorie energy deficit. To maintain weight loss, you're trying to produce essentially no deficit. You just want to maintain it at this reduced body weight at the new metabolic rate level. So the approaches need to be slightly different. And I think this is going to be this is the critical issue going forward, because we can produce some weight loss. Keeping it off is the issue. So the NIH sponsored a workshop on this, and the results of that workshop are published in Obesity, that fantastic journal, of which I'm the associate editor. So you can get that. That's free too. So weight loss maintenance. I mean, how we need to go about addressing that in the future is a real critical issue. Good point.
Hi, thank you for the talk. Do you think The Biggest Loser has had any impact nationally on weight loss?
Biggest Loser. Yeah.
You probably don't watch too much TV.
Yeah. You know, the Biggest Loser, and there's a new one, Extreme Weight Loss, that's actually done with the University of Colorado. It's very interesting. You know, that they're entertainment. So they're telling stories. They're telling stories about the individual. You know, from my perspective, I think we need to listen to people who are struggling with this, because I think we have a lot to learn from them. And so their stories, I think, are valuable. So I think personalizing this struggle, I think it's a great advantage. Now, having said that, this is drama. It's not real life. So what's really going on behind the scenes in those shows is that in order to produce that extreme weight loss, the behaviors are not what you see on the screen. There's a lot of aerobic activity that's going on, because that's really to produce greater caloric deficits. So you see people working out in the gym with the weights and everything. No. For every 15 minutes you're seeing of that, they're doing 1,000 minutes on the treadmill. You know, so it's not entirely entirely accurate of what's going on. The other thing is that it doesn't make the point of how difficult it is for people to actually do this within the context of their normal lives, the context of having a job, having a family, having children, having older parents you need to care for. You know, so it doesn't make that. You know, I think that those competing demands, these people, their job is to win the challenge. Yeah. Don't you agree? Yeah.
One last question.
Do you have any comment on geographic variation in the weight problems?
Isn't that interesting? You know, I have a house in New Orleans, and I have a house in Mount Crested Butte. So, and of course, Colorado is on average the skinniest state, and New Orleans is number 2 behind Mississippi. So, I mean, there's an enormous difference there. So several things are going on. First, in Colorado, there is an energy cost of altitude. So they've got an advantage there. The other thing is, I think this idea of the social aspects of obesity. Certainly in New Orleans, it's more normative to be overweight, or maybe even obese, depending on also in certain social classes. And in Colorado, I think there's contagion of this healthy lifestyle. This doesn't mean that we don't have a bell-shaped distribution in both. So, yeah. Thank you.